Hi, everybody. Thanks for coming tonight. I am Tom Santacandro. I represent the towns of Ashland and Framingham. And tonight we're going to explore, essentially, it's Healthcare Part 2 for Massachusetts. This is the second healthcare forum we've had. We had one earlier in the spring where we looked and explored at the single-payer issue, looking at all aspects of that. Tonight we're going to look at how do we make healthcare affordable in Massachusetts? We have a great panel of experts, and it should be a great discussion of what's going on. Many of you know what's happened here in Massachusetts. We were the first state to enact comprehensive healthcare laws, where we required every citizen in Massachusetts to have healthcare insurance. And what that did was ensure that now 98% of our population has adequate comprehensive health care, and I believe 100% of our children. So we are really on the leading edge of health care. Since we enacted this here in Massachusetts, the federal government, seeing what great visionaries we were in Massachusetts, enacted a similar law based on the similar principles. But we are here in Massachusetts 5 years ahead of the federal government. So in Massachusetts, in this legislative session and signed by Governor Patrick, we did a comprehensive health care cost containment legislation, still looking at the issue not only of affordability, but also of quality and ensuring quality and making sure that everyone still had health care. One of the concerns that we have and why we all talk about health care is the larger and larger portion that healthcare is taking up in our budget and taking up in everybody's budget for that matter. What we're seeing is that our gross state product is growing by 3 to 4% a year, and the healthcare costs are rising, I believe, 7 to 8% per year. Last year, healthcare costs made up 41% of our budget. It's a huge part of the budget, and it's a huge cost for us. So healthcare costs are not just a huge cost for the state, they're costs for anyone here in Massachusetts. Costs for people doing business in Massachusetts, costs for small businesses, employers, and what we're seeing and the pressure we feel is in the legislature is the cost for municipal governments, how much it costs municipal governments to provide health care to their employees, whether it's teachers, firefighters, or police officers. It's making up a bigger and bigger portion of our budget, and we need to take control over that. And so I have this panel of experts with me tonight, and they're going to give us or talk to us about the types of work that they've been doing. To my far left and to your far right, we have Ben Day, who is the current director of MassCare. And MassCare's mission is to ensure that all residents of Massachusetts have access to comprehensive, quality, affordable, and equitable health care through a single-payer system. And that's where he differs from everybody else, is that everybody on the panel wants comprehensive, quality, affordable, and equitable health care, but he's looking at it through the single-payer lens. We also have Karen Seng, who is with the she's an assistant attorney general from the office of Martha Coakley, the attorney general in Massachusetts. She's been looking at the examination of annual health care cost drivers, and she's managed a team of experts in analyzing information received from 24 subpoenas and depositions, resulting in the Attorney General's groundbreaking 2010-2011 reports on healthcare and healthcare market functioning. And finally, we have Representative Stephen Walsh, who's the chairman of the Healthcare Finance Committee, and he co-authored the landmark 2012 Cost Containment Healthcare Bill, which aims to save Massachusetts over $200 billion over the next 15 years. He's going to discuss the mechanism that the bill uses to find these cost savings and how we're going to look to move forward. Stephen is my colleague in the legislature. He's in the House of Representatives, and I have great respect for him. He's done a phenomenal job on this, really doing the the yeoman's task of getting this all under control. So thank you guys for being here. The plan is to have these folks each do a presentation, and then we're going to take questions from the audience and get into a discussion of what's going on. And first, we are going to start with, I believe, Ben Day.
All right,
So
ready.
take it away.
Well, hello everyone. How are y'all doing? Doing all right? So it is now T-minus 45 minutes until the first debate, the Scott Brown-Elizabeth Warren debate. So my first question is, what are you all doing here? But we're going to try and keep it really brief, I think, and move it along so you guys can get back and catch it, and hopefully you all have, TiVo and DVR. So I'm very glad that the topic this year is cost control, broadly speaking, even broader than single payer, because it is probably one of the hardest policy questions for people to get their head around. What exactly is it that's driving costs up? Everyone knows how high the costs are, and everyone knows how destructive the consequences of our high healthcare costs are. But actually identifying what it is that's responsible for driving those costs up is very, very difficult. There's a million different reasons, and the only thing more difficult than the policy of cost control is the politics of it. Because every dollar of money that you save in premiums is a dollar that somebody loses somewhere in the healthcare industry. So it's very difficult to pass cost control because it means potentially losing jobs, potentially reducing income to someone in the industry. So I have sort of a cost control training that I often do, but we don't have time for training, so I'm going to, instead of having an interactive version, I'm just going to zip through. So if you could just flip to the first one. This is just showing healthcare costs of the United States versus all of the other developed nations in the world, basically. The only thing you need to know is that extraordinarily high line on the top is the United States, and all of the other colored lines are the other countries in the developed world. So we are really an outlier. We literally spend twice as much as the next highest spending country on that graph. Next slide. So in the training, I like to ask people to just write out a list of all the different explanations for what drives our healthcare costs up. What could possibly explain that gap between the US and other countries? Because we actually don't have much better health outcomes than those other countries. We have shorter life expectancy, higher mortality, infant mortality rates. We're not getting anything for that money. And the list that people give is extraordinary. You can see it's inadequate prevention, behavioral factors like obesity rates, smoking, drinking, aging population, racial and ethnic makeup of the US, chronic illnesses like diabetes, heart disease, all the way through overuse of care, fee-for-service, low-cost transparency. Republicans like to blame insurance companies, that if you have insurance, you can just go to the doctor as much as you want. Using the emergency room as your sort of clinic, all the way down through poor electronic health records, high costs of drugs, and so on and so forth. So to simplify this, I've sort of grouped them into three broad groups so we can try and narrow down what is the real factor that explains the difference between the United States high cost and those other countries. So the first list that are sort of highlighted red there, those are all things that essentially say the United States is sicker than other countries, that we face more health issues than other countries. This is inadequate prevention, behavioral factors, chronic illnesses. The second group, which is in the next slide, highlighted red, basically says that we use more care than other countries. And these are also explanations for why our costs are rising. Is it because our country is becoming sicker, that we're aging? Is it because we're using more and more care? There's a lot of evidence to show that we overuse especially imaging services like MRIs and CAT scans, and there's a lot of procedures we overuse. And then this last group, which I highlight red, the third sort of big explanation for rising costs, is that the same care just costs more here. And the same care is costing more and more and more from year to year to year. So I like, just as an experiment, and I'll pause for 30 seconds, think about which of these do you think are actually the true driving factor between our healthcare costs. Which of these three is sort of a truth? Which one is a myth? And of those that are actually drivers, do they explain a lot or just a little bit of our high healthcare costs? Just mull it over for 15 seconds, and then I'll ruin the experiment for you and go into the evidence that we have. All right, moving on. So the category number one is actually a myth. The United States is actually healthier than peer countries, peer developed countries. This is a list of sort of disease categories, and you can see there's three areas where we are worse off than other countries. Diabetes, we are much, much worse off in terms of disease prevalence. and we are slightly more worse off in terms of cancer incidence and trauma-related disorders. But we are better off in every other category. That includes asthma, hypertension, mental disorders, and heart conditions. And the result is, if you go to the next one, we should be saving $57 to $70 billion compared to other countries. That is, if you moved our population to France and treated it in the French healthcare system, it should cost $70 billion less than France pays to care for their population. So that's category number one. There's obviously some areas where we're sicker, but in general, we are a healthier population. And that's actually mostly because we have such a large immigrant population in the United States who are generally younger and healthier. Next category is, so the last two categories were utilization. We use much more care than other countries. And the third category was prices. The same care costs more in the United States. And there's overwhelming consensus in the literature after decades of research that we do not use more care than other countries, and we are not using more and more and more care over time, but it's really the prices. Getting the same amount of care in the United States costs more. And there, again, just like disease prevalence, there are areas where we definitely overuse care and where overutilization is rising. Like I mentioned, especially imaging services. There's some procedures like cardiac stents that we overuse. But all in all, so this is actually a very famous article that was, I think it was back in 2003, published in Health Affairs by Huey Reinhardt and a bunch of his colleagues, called "It's the Price is Stupid." And the subtitle says, "Higher health spending but lower use of health services adds up to much higher prices in the United States than in any other OECD country." And there's a dozen other studies, but none of them have as clever of a title as this one, so I put it up there. But if you can switch to the next slide, this is physician visits per capita. You can see the United States is really at the bottom of the pack among developed countries. Less than 3 visits per person to the doctor. Next slide is hospital stays. We're also among the bottom of the pack in terms of hospital visits in the United States. There's a couple of others that are lower this, and the last one is average length of stay, and we have a very low average length of stay in the hospital. And next slide. The real driver is, of course, the costs. The cost for providing essentially the same care in the United States is much higher than in other countries. This was a horrible graph, but a great finding from the McKinsey Global Institute, which actually looked at which areas are we spending more than other countries. And you can see that more than 2/3 of the excess of what we spend above and beyond what other countries do is in outpatient services. And then a little bit in inpatient services, prescription drugs, and other areas. Next slide. So I'm going to switch to talking about single-payer healthcare, because the single biggest, most salient difference between the United States and those other countries that are spending half or less of what we are is that they have universal public healthcare systems. They vary a little bit, but in general, they're all what we call a single-payer system, or very like a single-payer system, where they have a public fund. Usually the money is paid through taxes, either a payroll tax or an income tax, and all of that money is distributed by the public fund to hospitals and providers and doctors. This is a map of the world showing countries with universal health care. And you can see that not only does the entire developed world have universal health care essentially, but a growing number of countries in the developing world are overtaking us and establishing universal health care. That has Mexico as green. Actually, this year in 2012, Mexico finished their 10-year plan to achieve universal health care, so they would be blue if we redid this map today. Next one. So this is a simple box explanation of how single payer works. And you can think of it, it's a little bit like how our public education system works. We pay through taxes. Public education is entitlement. The state allocates money to schools. Or you can think of it as Medicare, our Medicare plan, which is sort of our single payer system for seniors once you hit the age of 65. We all pay into a payroll tax throughout our life, our working life. And then when we turn 65, that money comes back to us in the form of a universal health care plan. So next slide is how our healthcare system works. We pay taxes to pay for our public plans, which are Medicare and Medicaid. Then we pay premiums to private insurance plans. There's hundreds of them. And then we also pay the highest level of out-of-pocket costs of any country in the world. So we pay extraordinarily high deductibles and co-payments directly to healthcare providers. And the result of this, if you flip to the next one, is that we have extraordinarily high administrative waste in the United States. And the reason is, there's two reasons. One is that private insurance companies have much higher administrative overhead than public plans. So in Massachusetts, our private insurance plans spend about 10% on overhead. So that means 10 cents of every dollar you give to your insurance industry is skimmed off, used for something before it ever reaches a provider. Our public plans like Medicare have 2% overhead. And countries with universal health care also, their whole insurance system is about 2% overhead. So right there, and in some states, insurance companies spend 20 to 30% overhead. So that means you're losing 10 cents to 25 cents of every dollar just at the private insurance level. But then another level of administrative waste is at the level of providers. So imagine you're a hospital or a doctor. In Canada, for example, the billing department at Toronto General Hospital has 2 billing people working for it. At least it did 8 years ago when somebody did this study. And they mostly deal with Americans. And the reason they have such a tiny billing department is because the province essentially writes Toronto General a budget, a check at the beginning of every month that's adequate to cover all their medical needs, the patient population they have to treat, and that's it. They don't bill patients, they don't bill insurance companies, they don't fight with insurance companies. The Mass General billing department had over 300 people in its billing department at the time that this study was done. And that's because essentially every insurance company has a different set of rules, what they cover. Every insurance company has multiple plans that have different things that they cover. And they deny as many claims as they possibly can get away with. And the billing department and every single staff at every provider institution spends an extraordinary amount of their time fighting that billing process, trying to get their patients covered and trying to figure out what's covered and what's not covered. So all told, we spend over 30% of our total healthcare dollars on administrative waste. And that, when we just compare us to Canada, we spend twice as much as Canada per person. Half of that difference is explained by administrative waste. So that's a huge deal. If you, So this last slide was just the insurance costs. Could you go back one? Sorry. The last slide, insurance administration costs in the US versus other countries. You can see we spend over $500 per person, and that's back 2010. Every other country is closer to $100, $200 per person. Next one is hospital administration. We spend $500 per person on hospital administration. Canada spends less than $100. And then the next one, this sort of graphically demonstrates it. This was a study looking at aortic aneurysms in Canada and the United States. The blue is how much we spend in the US and Canada just on the clinical procedure of just doing the actual aortic aneurysm repair. And they're pretty similar costs, but once you add on the red, which is the administrative costs, suddenly the United States, we spend 1/3 more for that same procedure than Canada does. And it's similar outcome for drug costs, which are, this is a slide showing how much more we pay than Canada for the same exact drugs. You can see we pay about 2 to 3 times as much for almost most of these drugs, many of which are manufactured in the United States. And the reason is that in a single payer system, there's a government pool, one large insurance plan, and they can essentially negotiate low rates with drug companies. It has to be enough for them to make money, or they won't sell to the country. But they can say, as a huge bulk purchasing entity, they can say, look, you can take this price or you're going to lose the entire population of Canada. And every country in the world pays less for drugs than we do. When you have 100 different insurance plans, none of them have the bulk, none of them have the power necessary to negotiate low drug costs with manufacturers. So that's the end of the slide. There's actually a lot of other ways in which a single-payer healthcare system brings those costs down and explains how all those other countries do so much better than we do. And in part it is that a single-payer system also lets you budget and plan your health resources. So you can actually decide where resources are needed, and you can decide where they're wasteful. We don't have planning capacity across our whole healthcare system. I lived in England for a while, for example, and England had a primary care shortage just like we do. And what they decided to do is essentially double the pay for primary care physicians overnight. And 2 to 3 years later, there was no primary care shortage in the UK. We can't do that in the United States because we don't have that planning capacity across the whole system. It's sort of a free market, free-for-all, and therefore we need to redirect resources to them. It's sort of a free market, free-for-all. And in this case, in the case of insurance, competition actually drives up costs instead of driving it down. So I'll rest my case there, and I'm really looking forward to the other speakers. So.
Great. Thank you very much, Ben. Next, we're going to have Karen Singh, who is the Assistant Attorney General working for Attorney General Martha Coakley. Go ahead, Karen.
So it's so good to see so many of you here tonight. I think all of us around the table, living and breathing healthcare in our day jobs, understand that to tackle this enormous problem of healthcare cost growth, it really requires a shared responsibility. And we're very proud of Massachusetts when enacting universal healthcare in 2006. It was very much a shared responsibility between government, insurers, providers, employers, consumers, the full continuum of stakeholders. And so taking this important step of better educating yourselves as to what is going on behind this sometimes very opaque veil of healthcare is critically important. Because if you can imagine in any market that you function in, whether it's purchasing groceries or purchasing a car, it very much is the consumer who stands in the shoes of the group, the purchaser that helps move the market. And if we took a poll tonight, how many people sitting here in the room, the last time that you had to go in for a medical procedure, had any idea how much your insurance company paid the hospital or the physician for the procedure? It's very, very difficult to get just basic price information in healthcare, and that is the linchpin of all functional markets. So what I'm going to do is I'm going to take the wonderful introduction and context that Ben has provided and focus on the piece that he left us with, which is prices are higher in the United States. Prices play a significant role in driving healthcare costs here. Why is that? And I think it will make for a nice seg because the remarks I will provide will give you a sense of why prices are increasing, why they are driving costs, but also to leave you with some very positive news about some elements of the recently enacted Chapter 224, which Representative Walsh will speak more to. So if we go to first slide, Scott.
It doesn't seem to be loading, fortunately. Is it gonna?
You want me to come around?
Sure.
You've got it saved?
Here comes IT support.
Jane of all trades, right? Okay.
It's a PPSX file.
And it's just not loading.
No.
Which one?
Do you want to have Steve go?
Do you have where's the name of the file?
It's healthcare. So maybe can I just, is this one?
Yeah, let's just use the PDF, even though it's harder to slide, I think.
Okay. Sorry about that.
Not at all.
Thank you, Jane.
So you'll have to scroll instead. Sorry about that, Scott, but see if we can get to the next slide. So as Representative Sanacandro already gave you a preview of, Massachusetts healthcare reform, the structure that we adopted in 2006 really was the foundation on which the Federal Affordable Care Act was built. And many of the insurance market reforms that you see in the first row of this table, as well as the universal access that happened in 2006, are contained within the Federal Health Care Reform Bill. This has been, if there's one takeaway from this slide, it's that it has been a gradual process, incremental, of building on years and years of work and shared responsibility, starting back from the 1990s. And we've made a commitment in this state every year since 2006, every legislative session. In 2008, 2002, 2010, and 2012, there have been major healthcare reform bills that have addressed increased transparency so that as a result of the 2008 Healthcare Reform Bill, Chapter 305, my office was tasked with an authority that is unique in the country to issue subpoenas to healthcare insurers and healthcare providers to obtain documents and hard data, as well as testimony under oath as to the black box process of how the insurance company is negotiating with the provider for that healthcare price that the insurance company is paying every time you go to the doctor's office or you go to the hospital. There was very much a veil of secrecy and confidentiality around that type of information. It was so bound up in contract confidentiality clauses that it really took compulsory subpoena power to bring that vast, vast body of data to light. And in my 8 years of practice, I can say this is the first time in issuing a subpoena that the recipient said, thank you. Here's an opportunity where we can tell our story. It's compulsory that we provide this information and we better understand how the market is working in healthcare. So that was a major piece of 2008. In 2010, as a result of our first year examination, we put forth some findings that I'll get into, and many of them are translated into a major piece of legislation that now says the overall aggregate healthcare price of any given provider institution, whether it's a hospital, a doctor's office, or an ambulatory center, it needs to be public. It needs to be transparent, and we're going to publish that on an annual basis so people can access that. Similar requirements were put in place for other key metrics. The same way when you go shop for automobiles and you can count on the miles per gallon rating to be consistent and a uniform metric and one that's clear and transparent, many more of those metrics are transparent today. And I'll leave the last row in the table for my colleague to my right to talk more about the very significant and remarkable reforms that were passed in July. So in the next slide, just a highlight of our major findings on what is happening in the market, how are these healthcare prices being negotiated between insurance companies and between providers. First, we found that there is wide variation. If you'll go to the next slide, I'll go through them one by one. That there is wide variation in the prices that are being paid in the healthcare market. So we focused our examination on the commercial health insurance market. So let's set aside Medicare and Medicaid and talk about in Massachusetts, that's Blue Cross, Harvard Pilgrim, Tufts Health Plan, Fallon Community Health Plan, Health New England. These are 5 of the top largest private payers in Massachusetts. When they sit down to negotiate with different hospitals and different physician groups, the providers end up with a very, very different rate. This particular slide shows you hospitals, all 70 in Massachusetts, from low payments on the left to high payments on the right. This is an aggregate weighted price that is adjusted for the same mix of services that all hospitals provide, and it also reflects the acuity or the sickness of the patients that the hospital treats. So this is adjusted such that to the far right, the hospitals that are paid a lot more, it's not because they're treating sicker patients. So you see wide variation in prices. Well, this happens in other markets too. A BMW can cost a lot more than other types of cars. So the next logical question is, how much is too much? Is that high price tied to value? And you can see on this next slide that variations in price are not adequately explained by value-based factors. So one of the biggest things you'd want to look at is quality. And so our office, we worked with a team of healthcare experts, including well-established, well-vetted quality experts and physicians, experts in the field. And we looked at every publicly available, well-accepted national standardized quality metric. And our work confirms many years of research that variation in quality does not track variation in price. This particular slide shows all of the hospitals in Massachusetts, and it shows that their quality performance, which is the height of the blue bar, clusters very tightly, and that 75 to 85% of Massachusetts hospitals outperform the national average on a daily basis. Our office looked at a series of other factors as well, such as, again, the intensity of the patients that the hospital is taking care of, or the mix of patients that the hospital takes care of? Are they taking care of a lot of poorer patients, perhaps patients with Medicaid insurance, which tends to pay less than private payers pay? And so perhaps the question would be, are you getting paid higher commercial payments to help subsidize that arguably underpaid public payer? And across a series of 6 to 7 factors that we examined, there wasn't that relationship between value and price. So the next slide shows you the real story behind higher prices for some providers not tied to value. It comes down to your bargaining leverage. And that's something that Ben got into when he talked about having enough size and clout to get better prices from a drug company. Certainly if you're in the entire country of Canada, I would hope you would have some clout. So here, some provider systems are bigger than others. Some have higher brand reputation. In a market where consumers don't know what the underlying price is, you might go on word of mouth, you might go on brand reputation, you just don't have necessarily, or you haven't had up until recently, reliable metrics to look at to evaluate for yourselves, to be prudent purchasers of care. So what you see on this graph is on the x-axis, the horizontal axis, you have the price that the hospital system commands. Each bubble represents a different provider system. And then on the vertical axis, you can see a measurement of the total revenue that the particular provider receives from this insurance company. In other words, the vertical axis says, how important is this provider system to the insurance company? And for provider systems that see a lot of members for a particular insurance company, they're really important. That insurance company cannot cancel its contract with the provider. It would upset a lot of its members. Finally, the size of the bubble represents the number of patients from that insurance company that are cared for by that provider system. So you can see there is a correlation, a pattern between further to the right, higher prices tend to be systems that are bigger. They are taking care of more patients from that insurance company, and also higher up on the graph, they are receiving more revenue from that insurance system. Simply put, they are more indispensable. They have more clout when negotiating with that system. The next slide seeks to transition a little bit into a concept many of you may have heard of regarding risk contracting or global payments or risk budgets. It's a form of paying for healthcare services. It's not a single payment for every unit of service that gets dispensed, but rather providers are paid a total global amount for the care of their population. The idea is to create incentives to manage responsibly within that budget and to coordinate care and to find the efficiencies. What our examination found is that although for many years following the 1990s, there was a move away from global payments in Massachusetts, there have been a core group of 6 to 8 providers that have stayed on global payments throughout. And you see the providers in this graph in red bars. Those are globally paid providers, and blue bars are those that are paid on a fee-for-service payment method. For every service they deliver, they're paid a price. And you can also see a yellow bubble above all but one of the red bars. That yellow bubble shows you that each of those providers has been paid on a global capitated basis for more than 5 years. So these are mature, established systems, well-versed in using global payments. And if paying on a global basis in our market to date has resulted in cost savings, we would expect these systems with 5, 10, 15 years of experience managing global payments to be able to see some of those cost savings. This slide, in my view, should not be taken as a condemnation of global payments itself, but rather further evidence that that underlying market dysfunction, that market dynamic that I described, where value and price are not being tied together, continues whether it's a fee-for-service price or a global price. Those with stronger leverage are able to command a larger global budget, even under an alternative payment method. So I think one of our recommendations from our office has been, as we move forward with this important global payment initiative, to be mindful of the underlying market dynamics. In short, what this graph shows is if costs were lower for those in red, who are paid on a globally paid basis, the height of their bar should be lower and they should drift to the left side of the graph, and they don't. Not to date, at least, but the promise and what we're working toward is to make that happen. So the next slide just gives you a basic flavor of really what Ben said, what's driving healthcare costs. So this shows for the last 6 years in Massachusetts since 2005, take all of the growth in healthcare costs across the state and tell me what percentage was because of pure changes in price. I'm paying you more this year than I did last year for the same services. And then that's shown in blue. So that's well over 50% of the growth for each year of the last 7 years. In green at the top, you see utilization. So my takeaway here is that 25% of all healthcare cost growth is we're using more services. So that's still significant. That's still definitely important to get at. They're both important factors, and that's my main takeaway. In the middle, you see additional factors called provider mix and service mix. And more or less, that is basically saying service mix, we're substituting higher cost services in year 2 versus in the previous year for taking care of the same ailment. If you bust your knee, do you get physical therapy, which is slightly less expensive, or surgery, which is more expensive? Both, let's say, are equally effective, but we are drifting towards the more complex, more intensive, more expensive services. The final slide is really just, it's food for thought. We found something during our last 2 years of examinations that is compelling, but what it really says is we need to do further study. So this complex slide, what we did is we looked at total healthcare spending on a per capita basis. So how much is spent on this patient, this patient, this patient, this patient. And all of that information is available through Blue Cross, through Harvard Pilgrim, through Tufts Health Plan. All of the health insurance companies know how much you, individual patient, is consuming in healthcare costs in a given year. They have to know because they're helping to pay for it, and they have to be able to figure out what their premium should be, how much they should charge you next year. And we took all of that information and we lined it up by all 600 zip codes in Massachusetts. And so we said in the Cambridge zip code, in the Ashland zip code, in the Boston zip code, are there differences in total medical spending by zip code? And it's also adjusted for health status, meaning once the adjustment is made, the numbers zip code to zip code, if there are any differences, it's not reflecting the fact that one zip code is sicker than the other, and that's why they're spending more. It's health status adjusted. It's apples to apples. And we found that there is geographic variation in spending. Certainly in higher cost communities in general, like Boston, more expensive urban settings, there's a difference there. But then we matched it up with something very interesting. We matched it up with the affluence of the community. That's income data that we received from the IRS, also by zip code. And we saw that there was a pattern we took those 600 zip codes and we divided them into 5 cohorts of equal sizes. So 20%, 120 zip codes in each cohort for 5 equal cohorts. And it turns out that if you look to the far left of this slide, that bar represents the 20% of Massachusetts with the lowest total medical spending, sort of the least is spent on care on average. And then each color within that bar shows average household income. It shows affluence, if you will, the income data. And in the royal blue, you see that 50% of the households that have sort of lower total medical expenses are also the lower income zip codes with that IRS data. And correspondingly to the far right of the graph, nearly 60% of the zip codes in which there's the highest health status adjusted total medical spending, nearly 60% of those zip codes are the highest income zip codes. This begs a lot of questions. We are just beginning our further analysis in our ongoing annual cost containment work. We do this work every year, and some questions range from, do folks from higher income areas tend to have jobs that give you paid sick days, so they're able to get to the doctor more often? Are they better, do they tend to be better educated, better advocates for their care? Can they get more discretionary elective services because of their advocacy ability? There's a whole range of questions, important questions, that this raises. It also raises the potential question that because those from lower income neighborhoods have lower health status adjusted spending, the premiums that they pay may not reflect the fact that their spending is actually lower. And there's a real question of whether there are cross-subsidies happening within the system. I will leave you with a few thoughts in the final slide that I hope are a good seg. There are 3 concepts as a result of the Attorney General's findings and her work since 2009 that she really sought to work with her sister agencies, with the legislature, in implementing so that we have a strong foundation going forward as a Commonwealth to address the challenges that have been outlined. The first is price transparency for consumers, and this is found in Chapter 224, where you will be able to get real-time information from your insurance company and even to a certain extent from your provider about how much something costs before you go in. That's essential to encourage prudent purchasing and to put you in the driver's seat. The second is enhanced market oversight of provider organizations, and I'm sure Steve will get more into that, but I will just say in general, we have a very robust division of insurance that provides comprehensive oversight of the insurance agency, but as health provider organizations have gotten growingly complex, it's not just the local community hospital down the street anymore. It really is multi-hospital systems with thousands of affiliated physicians. They are very complex, very large, and there's actually very little data reporting in the Commonwealth about that. So we now have a health policy commission that is really a counterpart to the Division of Insurance to provide the holistic view on the provider side. And third and finally, what's happening to that first waterfall, that price waterfall? We've got a lot of difference in prices, but there's fat in the system. It's not efficient. It's not tied to value. There's going to be public reporting at the Division of Insurance. Every carrier, every insurance company has to report the percent variation in prices in their networks. And there are some provisions regarding annual healthcare cost growth review by this new Health Policy Commission to tie that together and hopefully to move forward together with that shared responsibility.
Thank you, Karen. Next, we have Chairman Stephen Walsh, who is the House Chair of the Healthcare Finance Committee and the co-author of the landmark 2012 Cost Containment Healthcare Bill, which, like I said, aims to save $200 billion for Massachusetts over the next 15 years.
Thank you,
Stephen. Thank
you. I have a. I'll give your eyes a rest. I won't use a PowerPoint. I'll just talk. You can close your eyes if you fall asleep. That's okay too. I have the unique opportunity to not necessarily discuss what I think we should do or any ideas of findings. I can tell you what we did and why we did it and how I think it's going to help you in the future. And I can tell you that it's a better bill because of the work that Ben has done and the work that he has and the counsel he has given us through the process, and Karen and her office and the work that Attorney General Martha Coakley has done has contributed to this being a very, very good product. And certainly your own representative, Chairman Santacandra, who does such an extraordinary job on your behalf at the State House. And he is one of the main reasons why we have medical malpractice reform in this bill, which I'll get to in a little bit, which is about 2.5% of our total medical spend. I also like to look at this bill a little differently, and Karen probably heard me talk about this last night, and my Chief of Staff, Josh, has heard me tell the story 1,000 times now, but I don't look at this, I don't look at healthcare through the eyes of a government person or of a bureaucrat or of an elected official. I look at it through the eyes of the patient, which is really how we all should be looking at healthcare. And what we have sought to do here, and I think we have successfully done, is move the leverage from an insurance company or from a provider or from a large hospital system to you, the patient. And I learned about this 18 months ago when my wife and I had twins at Brigham and Women's Hospital, and when my young son Miles had a heart defect. And when he was born, we had a neonatal team immediately take him from the room and over that long and lonely bridge that separates Brigham and Women's Hospital from Children's Hospital. He had to be rushed into the cardiac ICU unit. He was intubated in the hallway halfway between the two hospitals, and we spent over the next year 96 nights in the hospital. I stayed every one of those nights in the windowsill. And I visited all 14 hospitals in the Longwood Medical Center area to try to find out what worked and what didn't work. And then I started to visit all of the hospitals in the state. And I think Josh and I got to 55 of the 64 licenses to try to understand better what our patients face on a regular basis. Because frankly, I didn't much care what the insurance company faces. I've cared a little bit what the doctor is facing, because doctors are now in a different situation as you see these large provider groups or these large conglomerate hospital organizations. So we tried to figure out what would work. We also looked at two other factors which are incredibly important to all of us in this room. Factor one is that we spent $66 billion last year in the Commonwealth on healthcare. $66 billion, more than anything else that we spend money on. And in the last 10 years, every single thing that you care about has decreased in funding to fund the increase in healthcare, whether it be public safety or social services or the environment or energy, whatever it might be, public safety, they said that education, it has gone down. So that we have got about $1 billion a year increase in healthcare each year since 1990. That's unsustainable, right? We're almost at 20% of our gross state product spent on healthcare now. So we tried to look at what isn't working for you and how we can save money. I'll outline some of the things that I think don't work for you and how we can make them right. The first thing is your medical records. You have no idea necessarily what's in it. So when you present at any particular hospital, provider organization, doctor's office, what ends up happening is you get over-tested and we all pay for it. That's the way it works, right? Every other technology or every other industry is 15 years ahead in technology than healthcare. Why is that? Because it's not in anyone's best interest for you to have that information. That drives costs up, right? Banks have figured this out with ATMs. You can get money anywhere in the world, because they figured out how to make it worth their while to make it a business line to be able to offer you money through an ATM. That is not the way it is in healthcare. So what we should do, and what we have done now in Massachusetts, is require by the year 2017 interoperable electronic medical records, so that you own and access your medical record. It's personal to you, and anywhere you go, you can get your doctor your information, so that you can see what's actually happening to you in real time. So that you don't, maybe if you're on vacation and you have to get rushed to the emergency room, you can't figure out what your medical history is, and you end up getting subjected to tests that you don't necessarily need. It drives cost up. It's not a huge cost driver, but it is a cost driver. Area two, Karen talked about a little bit, disclosure and transparency. I always use this example of Stop and Shop. It's as if you go to a Stop and Shop on this corner and a gallon of milk is $3.29. And you go over here to this Stop and Shop and it's $3,482. That you have no idea why. That is exactly the way healthcare works in Massachusetts and across the country. You have a right as a patient to know the cost, the quality, and the risks of anything that is being done to you that are associated with any test. You can't get that information right now. And that's not your doctor's fault, by the way. They don't have the information either. So on a Sunday afternoon when you may be at X hospital and you need an MRI, what they don't tell you is that downstairs in their own facility, they're charging you $1,800 for that. But down the street in a standalone facility, it's $575. Now, why don't you get to pick that? And why, if you pick the lower cost one, doesn't the premium in your health care go down? Why can't you be healthy, make good choices, and save money and see a reduction? Your health insurance has gone up 8, 9, or 10% every year for the last 10 years, no matter what you do. You can go to the gym every day for a year. I can go to an all-you-can-eat buffet every day for a year. Our health insurance is still going up exactly the same the next year, no matter what choice we make. Through disclosure and transparency, you'll at least be able to have that information at your fingertips in real time. So some of these games that are being played in terms of pricing, based on volume pricing or people pricing based on brand name or number of services, will begin to diminish because you'll have that information when you travel around. And most importantly, you'll be able to get quality. Right now, the problem with quality, you walk into any hospital in the state of the 64 or 65 hospitals, you're going to see a banner at the front door, and it's going to say best in the world at something. Who knows what that something is? It may be sprained ankles, but you will find a banner there because everybody is using whatever quality metrics makes them look best. We ought to agree on what the quality metrics is. 2 years ago in Chapter 288, we set up a statewide quality advisory council. In Chapter 224 this year, we have instructed them to finish their work and have an apples-to-apples comparison so that you get to see where you can get the best quality and care. Because what's happening now is folks are running to teaching hospitals, and some of them are the best in the world, by the way, but they're leaving their community hospitals behind. And what we're going to end up left with is nothing but high-cost providers. And when you have a small incident and you need a hospital 1 mile from your house a few years from now, that won't exist. That's the real problem. And when you see 4 or 5 or 6 hospital systems left in the Massachusetts and there's no more standalones, you will see costs begin to go up. Because what Ben talked about is absolutely real. In healthcare, when you have seen consolidation in healthcare in the Northeast, it's driven costs up. Everywhere else in the world and every other industry, when you see consolidation, it creates efficiencies and drives costs down. So that's something through disclosure and transparency that we address. Medical malpractice, 2.5% of $66 billion. We are not a litigious society by nature, but what happens in med-mal is doctors are taught from the first class that they take in medical school, don't tell the patient anything. Don't tell. You go see legal counsel before you say anything. So it may be something very, very simple. Maybe something simple that happened that you or your family just want answers. You just want to know what happened, and you don't get any closure in that. These cases take 7 years, they're extraordinarily expensive, and doctors win all the time anyway. They win 88% of the time in court. What Michigan had done, and a bill that's filed by Chairman Sanacandro here in Massachusetts that we adopted in this bill, says that first conversation, that early conversation, the doctor has the ability by law now to tell you what happened, to admit their mistake or error, so that you can be the judge of whether or not you want to move forward. You can understand what happened to you or a loved one. Oftentimes, that simple discussion is enough. Then there's a 90-day cooling off period where we encourage a settlement, and on the 91st day, you still want to sue? You have every right. You've given up no rights at all. But what you got is information, and the doctor was able to actually tell you something that they've never been able to tell you before. We also move some of the leverage. These large hospital systems, they've been capped at $20,000. $20,000. So why do we always go after the docs? Because if something happens at the largest hospital system in the world, the maximum that you can recover is $20,000. It's a holdover from the 1970s. So we increased that to $100,000 to begin to try to take some of that pressure off the individual doctors. What does that mean for them? It means that they don't practice defensive medicine. It means they don't give you tests that you don't need. You don't have to face the risks of that, the exposure of that, and the cost of that. It's a critical, critical piece. The next thing we look at was administrative simplification. Go to the doctors. How many pieces of paper do you get in the mail? 3, 4, 5. You get a bill, you get a statement of benefits, you get an explanation of benefits, you get a bill 30 days later as to what you paid, what you didn't pay. Then you get something called a balance bill, which it says in really small print on the bottom, this is not a bill, do not pay. But it comes with a remittance envelope and it comes with a tear-off, right? So if you send it in, they don't send it back. Right? How come American Express has figured out that at the end of the month, they can send you a bill with everything that you purchased, what you paid, and what you owe? Why can't we get that in healthcare? Why can't? Because it's not in the industry's best interest yet to simplify their administration. Because a third of any hospital, as Ben talked about, a third of any hospital is their billing department. Now, that's not their fault. This isn't anyone's fault. It's the system that has been set up that we live in. Now the system is broken. It's time to fix the system. So we force them into administrative simplification so that you can understand what was done to you, whether you were even at the doctor's on that particular date, what the charge was, and what you owe. It's fairly simple, and you should get that on a fairly regular basis so you can keep track and you can understand it. I talked about moving the leverage. The next area we looked at was consumer education, patient protection. One of the things that happened in the 90s with the first wave of HMOs or managed care was that people felt their care was rationed or their care was capitated. That is some of the challenges that people face when they're looking at single-payer systems in other countries. I don't necessarily want an insurance company making a decision for you and what's medically